Dear friends, let's continue our rehabilitation part regarding children. Those who was at our medical talk regarding spinal trauma, I think you already have some grasp idea about early rehabilitation. Our symposium is called Children's Rehabilitation Routes, and we are not surprised that we have this kind of name to that. Not long ago we signed our decree. On the 23rd we signed our decree to help kids for this kind of medical rehabilitation. And we see that half of our speakers actually participated in that initiative. They met citizens, communicated with different patients, and our rehabilitation route is a very important thing. For example, if a child has a congenital disease or was traumatized or something else, how will he or she provide a certain rehabilitation? How will they be moving within the area of all those medical establishments if they became totally handicapped? It's a very important issue, but now I would like to introduce all our speakers. Svetlana Vaulna, candidate for medical sciences, professor and major medical rehabilitation specialist, also head of the emergency medical assistance for children. Also Inga Plotnikova, representative of the Scientific Practical Center or Child Psychoneurology. Natalia Mamontova, head of the rehabilitation department and neurologist, rehabilitologist, and now she is in her first teaching cycle. She studies physical rehabilitation, and also she represents here children's emergency department. Mr. Tikhonov represents here Practical Center of Children Psychoneurology. Fufaeva Ekaterina, head of the Psychological Pedagogical Assistant Departments at the Children's Emergency Assistance Institute, Deputy Chief Director for Psychological Work at the Center of Speech Disorders and Rehabilitation, Serebrovskaya Olga Vasilyevna. And we, of course, decided to mention also rehabilitation at different resorts. Ponomaryova Ina Anatolievna, Chief Doctor at the Children Sanatorium, and she will be presenting here a presentation from a group of authors. Here is our panel composition, and these people will try to tell you about all those methodological approaches in the sphere of children's rehabilitation that we have to tackle today and to work with and develop in the future. And I would like to introduce myself as well. I'm here to develop a different multi-level interdisciplinary staged approach for children's rehabilitation. when I was preparing this presentation, I was thinking where I should start, and I decided to start with a quotation of Mr. Botkin. It was scientifically proven that you have a decent and properly tailored rehabilitation program, you can make 50%, up to 50% of severely ill patients back to their normal life, and it should be tailored on an individual basis. That was Botkin said last century, so it is still relevant today. According to the World Health Organization, 25% of patients require rehabilitation. 40-50% of outpatients need rehabilitation. According to Valchuk, over 60-65% need certain rehabilitation, and 53% of outpatients need this rehabilitation, and only 25% can simply be sent for a sanatorium rehabilitation. We could argue about those figures, but we are still analyzing these figures, and we decided to do it in Moscow. We have our own figures and percentage, and we would like to extrapolate a little bit more on that. Who we actually work with? We mostly work with newborns, so we have 120,000 deliveries per year. We have also 6% of it with premature delivery, and we have 7,000 newborns annually. We also have a lot of children, out of them with extremely low mass weight, which is less than 2 kilograms. So it means that potentially this is that group of people and we will have to work with long term. I mean, less than 1,000 grams, so less than 1 kilogram. We need to either work with these kids, either with a center for speech pathologists or a center for neurological disorders, or also work with them in other specialized establishments. As for the diseases, here are 6 major diseases. We can say here some tumors, some psychological disorders, also endocrinology problems, nerve-related problems. These are the group of people who account for that number of handicapped people. And so we should say that this mental disorders is ranked as the top problem, and particularly in Moscow, which stands Moscow a little bit apart from the rest of the country. We also have a lot of children who need really rehabilitation, and also we should cover not only mental disorders but also nerve systems. Unfortunately, this figure is still growing, but we have federal programs. They work in Russia and in Moscow in general, so we don't really have a tremendous increase of them. We even had quite an increase up to 2012, and then it went down and reached the threshold of 2003. This is that group of people that can be really complicated with all those spinal disorders. These are those measures, information about health state. We can see that these are people who were insured in Moscow and those who live in Moscow and outside in Moscow. But in total, we have right now almost 2 million young citizens who were officially registered within the territory of Moscow, and we see that the overall dynamics is quite positive. Well, something went wrong with the slide. in general, the number of diseases both in Moscow and Russia has been declining, but at the same time, the number of cases when they have to be taken to the hospital grows up. It means that we also have a bigger number of handicapped children, and this cohort really grows, and this is exactly what we will be focusing on, and will require certain rehabilitation, probably even multi-stage rehabilitation. So we have been talked a lot about the word rehabilitation. This is a set of medical, psychological, pedagogical, and other measures aimed at the maximum admissible recovery or compensation of affected or completely lost functions because of the disease or trauma. It doesn't matter. And now we are working with three categories of patients. These are patients with, you can see, yes, three different groups. Here we make a segregation between adults and children. If, for example, adults, we have central nerve systems as a separate sections, but here we decided to put the central and peripheral nerve system and put them together, because it's not possible to segregate them. When you get a very severe trauma, I mean a cranium trauma or others, you can understand that both central and peripheral nervous system can be affected, so we cannot segregate between the two, and we cannot rehabilitate them in different places. The same applied to the cerebral palsy or some inborn congenital abnormal conditions. We think that such children should be here brought together. We also have children with a problem with locomotorium, and also we decided to put separately oncologic diseases and cardiovascular. So over 4,000 kids after all those operations and cardio problems, we can see that the situation, even though improving, but we need a lot of little patients. Some of them do not require any rehabilitation, but we still work on that. We keep on working with different pathologies. What are our methodological basis? What do we have today as part of our normative basis? Today we in September 2013 we signed a special guideline of physical and rehabilitation medicine. It was officially signed, and in 2 or 3 months, Natalia Anatolievna, you know that we're about to finalize this part regarding physical rehabilitation for doctors. So far, we have trained specialists to do that, and now we proceeded to a new cycle, which is also organized at some of our departments in order to train even more people to be engaged in this domain. And in Moscow, we need to prepare a list of specialists that could be used for training, and we have to have a clear perception as to how it should be arranged. And we understand that it's going to be quite a big number. Even within a period of 2 or 3 months, or years, we won't be able to train all of them. I think that Tatiana Timofeyevna has done a lot, because she postponed this training process of preparation and shifted it by 3 years, because as for the adults, we also going to sign another guideline for rehabilitation starting from the beginning of 2021, which will have this obligatory provision for rehabilitation and training for that matter. So this is one of our decrees. We are guided by our table book, the White Book of Rehabilitation, that you can see here on the screen. Right now we have a second translated edition of this book. Those who hasn't read it, you should definitely read it. It is available, and it can be found at the Union of Rehabilitologists in Russia. There we can have a clear rehabilitation, what stands for the term physical rehabilitation, what we need it for, and how it works. A real table book. Our table book number 2 is an international classification of functioning. We work with affected functions. Of course, these functions they are triggered by some diseases, and they are based on an international classification of diseases. But we work with different functions, and we need to understand how to properly create this rehabilitation diagnosis and pick the right rehabilitation team. That's exactly what we're supposed to know, and our specialists of our scientific practical centers know how to do that. We also have a decree number 1705 that was signed back in 2012. We still stick to that document, and our children's order was also signed, and it will be put into force starting from the 1st of January to 2021. And of course, it will take some time to prepare for that. Okay, now let's talk about stage model of rehabilitation. We know how it works, and we know what's the stages of rehabilitation. Well, the first one is reanimation, intensive care units, also day to night inpatient care, where patients are taken for the first time ever after trauma, and the second time of rehabilitation is a special rehabilitation unit or center, and the third one is outpatient care. Then also we have special services to attend to our patients, and something that we are working also is telemedical services of medical rehabilitation, again being actively developed. Well, practically those who are taken on a 20 on a round the clock inpatient care, I mean these children, they need de facto 100% rehabilitation. Then these kids are taken to special beds, and here I decided to show on purpose to show you this information, because also World Health Organization decides on this kind of sequence, but life tells us so that that's exactly how it should be organized. 60-65% of patients on the specialist beds in those day to night inpatient care, they require rehabilitation. Then they can recover and leave the establishment, or they might need no rehabilitation, and probably they will only need some monitoring, but usually it amounts to no more than 30-35%, even though that threshold of 50% was mentioned. Some children need to be taken to some sanatorium or resort for rehabilitation, and then we also have 30-40% of children that need to be taken with different problems with central nervous system, and 25%, 25-30% with various injuries. These are new approaches that will be reflected. I would say have already been reflected in the new degree. Together with Inga Albertovna, we have been striving to achieve that. But finally, the Ministry of Health decided that we will focus on these curation stages. But of course, these levels will be replenished in form of an addendum to the decree, and it will be replenished by information from the international roster. And now let's look at the fifth level of curation. This is a very severe state where we have very affected functions. We can see apparently here in the international classification, it needs to be assessed properly, and if we don't do that, how we can take it to the fifth level if we don't have all those conditions in place. There could also be some acute situations, recurrence, or it could also be some comorbid comorbid diseases. This is the group that falls within the fifth group, the fourth level of curation. So this is severe or middle severe state. It requires monitoring regular permanence, which also reflected in the international classification. Well, quite an acute situation can be also accompanied by some other conditions, but you can find a decree at our website to check it out for more information. So the third level of curation, this is all that would either should be treated in patient basis or in a bad outpatient basis. We also have the second level of curation, also reflected in the terminology. Chronological remission stage can be combined with some qualifications of main disease.
Remission stage and also has high risk of complication occurrence. The second level of curation, light condition, and the first level is satisfactory condition with light disorders. Well, how these levels of curations are grouped in this rehabilitation stages? Well, at the first stage of rehabilitation, we have the first, the fifth, and the fourth level of curation, just to be quick. At the second stage to rehabilitation center, we have children with fourth, with third level of curation, as well as third level for the daytime inpatient hospital. And the third stage are children with third, second, and first level of curation. Then it will be more precisely deciphered and in the new decree on rehabilitation. And what are we doing in our rehabilitation? On the one hand, we cure a pathological condition, a main condition, but it's not the task of rehabilitation specialist. When we're speaking about first stage of rehabilitation, a rehabilitation specialist works together with the doctor of specialized department, and they work at a main pathological condition. And we, at this point, work to decrease the invalidities or expression of disorders, dysfunction of activity, and possible of social participation. That is what is described in White Book of Rehabilitation. That is something we work with. And a couple of theses, and very fast, what we have in Moscow, where we have first stage of medical rehabilitation in all clock-round inpatient hospitals, better or worse, but it's present almost everywhere. If we speak about the figures, then as to the results of 2018 to 2019, so the first stage of rehabilitations, around 140,000 children needed that. And that is how many children should be directed from this level to some different institutions. And we should also understand that almost everyone hospitalized and especially operated children, there are 110,000, they will need rehabilitation procedures. What kind of problems we face? Well, the problems, of course, in routing the child leaves the hospital, where he should be directed further on, because now we do not have in Department of Healthcare any rehabilitation births. However, we do not stop at that, and we continue working with these patients. And the Center of Children's Psychoneurology is, on the one hand, a specialized department or institution, but so actually they play a role of the second stage of rehabilitation for children with neurological pathology. And actually Department of Dedenov, Department of St. Vladimir is not a rehabilitation department. This is a rehabilitation department, and they're working as second stage of rehabilitation with the problems of moving. Our institution, we do not have the births for rehabilitation, but we take them for second stage at the rehabilitation. Very hard children with cranium spinal or combined trauma. And in nearest time, in Center of Specialized, we have 30 births of rehabilitation, and I do hope that they will be active starting from this year, and 30 births in the Speransky Hospital for neuro rehabilitation. I do hope that we will manage to do this. And the second stage of rehabilitation, these are the figures that we have, 70,000 children overall need a secondary stage of rehabilitation. And I have already mentioned these institutions. I see Olga Vasilievna is here because Center of Speech Pathology also takes some part of children with for rehabilitation, and we have a large help represented as a Center of Childhood, that is a Russian Center of Rehabilitation, where we direct Moscow children for rehabilitation procedures with the problems with nervous system and supporting motor system, and oncohematological and oncological pathology, Ruskaya Polya, from the center of Dmitry Rogachev, where we hospitalize children with oncological diseases. Also, we have quite good, quite well-equipped departments of the Center of Rehabilitation in the Department of Social Security, and that is actually, they normally take 6,000 or 7,000 children who go through rehabilitation at this birth. This is the arrangement we have. The third stage of rehabilitation, and here I will start speaking about the sanatorium resort treatment, because at 12 sanatoriums that we have in Healthcare Department of Moscow, they are actually secondary stage of rehabilitation. This year we will have considerable work, and we will try some sanatoriums to get a license for rehabilitation. We see who that can be, and overall 15,000 children from Moscow are sent to these sanatoriums, and if there are doctors from a primary link from polyclinics, it's very hard to arrange work with polyclinics, and they just do not send the children for treatment and to our sanatorium. And we believe that we've made impossible during these 2 years. We corrected age acceptance, and we hospitalize children till 4 or 15 years, and we have births, mother and children. And however, it is present, and we can actively use this part of work. And this is the sanatoriums that we have. We have broncho lungs, pulmonological, neurological sanatorium, and our sanatorium resort department of Institution of Emergency Surgery for Children. Now, as related to the third stage, that is inpatient treatment. We have the number of children, of disabled children, among those who are among the children populations, like 110,000 children need third stage of rehabilitation, and we have some not kind of misunderstanding, but actually polyclinics show data normally not for children specifically who got comprehensive rehabilitation, but separately how many got physiotherapeutic treatment, physical culture treatment, and we said that we should get this data in a more specific way. However, you see at the slide, well, 16.5 thousand children with distortion of central and peripheral nervous system, 36,000 with the problems of support motor system and somatic pathologies who need comprehensive rehabilitation at inpatient stage. Well, and it's quite clear that comprehensive rehabilitation cannot always be done in polyclinics, as long as the comprehensive rehabilitation presupposes not only physical motion component, but also cognitive component, psychological, pedagogical component. And we know perfectly well that specialists of psychological assistance, consultants, and work is not done. That there is a problem, and Anastasia Vladimirovna at the beginning of the year made a task for us to make analysis of what is done in territorial centers of social protection, because there they concentrate these specialists. And well, we thought over that, and we have a suggestion how to jointly use specialists of social security. And actually, of course, we should have, well, here the problem is like that. The rehabilitation service in districts is very disallocated. In somewhere it is a water treatment, but perfectly we need to have at least one institution, expert institution in a district, where we would have concentrated almost all kind of rehabilitation, and that is the institution. And maybe when we specifically analyze data and manage rehabilitation service in the district. And a couple of words about training. I have already said that as for training, we have a lot of work done. Now we are creating a list for the second cycle of training. Then there will be the third cycle, and here is a multidisciplinary team that is specified in the wider book of rehabilitation, which is specified in all the regulatory documents, and specialists which we need to train. So here is the number of specialists which we need to train. And the main part is not to take just and train specialists, but to teach them working in a multidisciplinary team. This is a separate direction. This is separate training, and I believe that's all. And just I would like to give the floor to Inga Albertovna. Well, please switch on my presentation. Dear colleagues, I represent my report. This is application of international classification of functioning in medical rehabilitation for children and teenagers. And I will allow myself to speculate upon our new regulatory basis for rehabilitation of children, in particular methodological recommendation of Ministry of Healthcare of Russia, dedicated to rehabilitation financed by obligatory medical insurance. As we know, in Russia, healthcare has one-channel financing, and medical rehabilitation of the first and second stage in the daytime and nighttime hospital should be paid by the Foundation of Obligatory Medical Insurance. And according to decree of December 2019, there is 18 clinical statistical groups for clock round in inpatient hospital and for in-house hospital as well. And of course there is a medical rehabilitation of children, and a little bit later I will speak about these things. So what is clinical statistic group? This is a group of diseases which are related to the one profile of medical assistance with the used methodology of diagnosis and usage patients and average resource of capacity. And in the nearest time, the task of medical rehabilitation consists in using a special system to assess the current status of a child and deficiency of his medical rehabilitation. Starting from the next year, we'll have the order, which is very hard to be elaborated, and finally it is confirmed at Ministry of Healthcare and Ministry of Justice, and Svetlana Albertovna has already said about the levels of curations, and soon we'll have differentiation of payment, and which identifies routing of the child of the first, third, or second stage of rehabilitation, considering the condition and functional deviations in terminology. And they also consider the competing or another pathology. The doctor, together with the members of multidisciplinary rehabilitation team, establishes the status. This is limits to the functioning and life cycle and for health, but they are based on true laboratorical measurements and true laboratory medical skills. Rehabilitation diagnosis, this is a medical conclusion and functional diagnosis of functional disorders, which is also expressed in the terminology of the same level and any level of detailization. Pay attention to this terminology additional to the diagnosis and rehabilitation potential. That is the indicator that assesses potential level of recovery, compensation for distorted functions at some period of time, considering individual compensatory capabilities and factors of environment, and all that is MKF terminology and our international classification terminology. And I would like to speak about ideology of international classification, which includes all the spectrums, not only of healthcare, but also components of well-being which are related to health, and it describes it in the terms of domains of health and domains related to health. This is unifying biopsychosocial model, which helps us to get distracted from considering the limitations for life only as not only the problems related to disease or trauma, and medical assistance is not the only way out, and at the same time we solve social problems of integration of disabled people in the society. The structure of international classification has two parts: functioning limits to the life and factors of the environment and personal factors, components for the organism. These are structures and functions, and active participation is a sphere of life, activity and participation. And if we're healthy, if a patient is healthy, he has complete functional structural holicity and participates in all spheres of life and society, depending on the age. Well, if this balance is distorted, we can actually change it due to technical means of specialization, and at that, the factors, all our available environment can improve or facilitate this structure. In the same way, contextual factors, our relation to disabled people, which keeps on changing but not as fast as we would like it to, also helps a child to get integrated into society. So, functions of the body. These are physiological functions of body systems, including psychical functions, structure of the organism, anatomical part of the body. We assess them from the position of their changing, not only just like that, but these are changes and distortions. Positive aspect, structural, functional holicity, and a negative aspect, fracture, amputation, is a distortion of the structure, and paraparesis is distortion of function of pulse, inducement, activity, active participation. Just speaking in primitive language, activity, it is our daily activity. We wake up, wash our face, and walk. In the participation of this hobby into life, a child goes to school, a child communicates with his friends, and we consider potential capability. We compare it with healthy people, you know, and actually potential capability is how he or she performs it in comparison to healthy people, and rehabilitation of how he got adjusted in real conditions, and how we assess limits to activity, limits of participation, factors of environment, positive and negative aspects. Further on, the rules of coding. We create a code of this condition on international classification system. We have this coding system. Let's speak about sensory distortion from the position of structure. Of course, this is a nervous distortion, and we will never understand why a child cannot speak if we do not assess at what level his structure is distorted, because distortion of speech or eyesight can be related to immediate distortion of the bodies and also to brain distortion. So sensor aphasia is a structure of brain. Brain shares, if we are speaking about this purely, this is the distortion of smart functions. It's out of the questions, and we see that there is a classification level, and every next level is more detailed, and it includes the previous one. That is cognitive functions, cognitive speech functions, and if we add members of multidisciplinary team, they say that this is perception of the language and perception of speech language, actually. And we work with speech specialists and our psychologists working with this perception of the speech. And also what is related to activity. The more figures we have after the letter, the more detailed level we have. So this code gets more and more detailed classification.
And if you talk about sensor aphasia, and this practical thing, that here we talk about communication and also dialogue with one person. And what does it lead to in terms of participation? We have a distortion of the process where the person acquires new skills and language-related skills. Here is a list of the structures, this one-level structure, and a list of all the parts, just a few functions. And here we have a more detailed classification. I have already said that we already have some basic sets for MKF, and I said basic set for example, cerebral palsy in the section mobility when for example, walking at short distance, depending on the GPS level, we can identify that. A few words about environmental factors, again taken by the basic set for cerebral palsy. Just look at different levels of digitalization and various classification based on that. That is not a full list, it's just for you as an example. So here we have some auxiliary means, tutors, and we have different means of rehabilitation and even codified our environment. Again, so far we don't have a program, but where we can find these codes very quickly. When you use this approach, it's not just a mechanical attribution of codes. We say that we assess everything from different angles and also positive, and that can be reached with the help of digital identifier that can put at the end of the codes and can identify all those distortions, structure of the bodies, and we have a scale from 0 to 4. We can see what kind of distortions we have and how many of them, and so it is then relates to our skills. For example, GMCFS, at least part of it. This is more about our activity, physical activity. For example, just walking or stairs, and we can see how it correlates to MKCF codes. As for the codification, there are some particularities. We might have here three figures, and the first figure is also how it is pronounced. The second indicator, if we don't have, for example, a full-fledged amputation, which is mentioned today, and so the third one is localization. That's what it looks like. It's very severe effects on limbs, and the second figure, number 2, this is a partial loss of hand, and for example here we have a specification whether it's left hand or right hand. As for the functions, they are codified only with the help of one figure, and just against this background and example of the tone of one line, we can see how it can also be attributed to the scalar. As for the activity and participation, it's very difficult to understand that, but here we still, for example, capacity. For example, we have an amputee, an amputated hand, and he walks with a prosthesis and walks just like other people. We have some problems with walking, and this is figure number 2. But if we try to imagine that this person jumps on one leg, it's quite difficult to jump on it, especially in Moscow, and apparently we have some limited mobility. If, for example, we have here a ramp rows and figure number 4, it means that a person or one in a wheelchair cannot come to work because there is no ramp. But if it is there, then this person will see that this problem can be tackled. You can see these environmental factors and code them together with the structures and functions. No, but what we do we need it for? Yes, we need to answer this question. We have so many scales, and probably we need to form a diagnosis. We need a lot of them, but how can we work on them? What do we need it for? And this MKF, for example, spinal atrophy in European countries. This spinal atrophy, in many cases, people can live up to 30 years and even have their children. But here we have just kids of palliative group, because here we have some change problems with neurons, and right now we have Spinraza is one of the drugs that can be used to cure this, to minimize all those violations. We can also have a positive impact on the protein exchange, but with provision that we don't have any barriers. But according to our policy, we cannot afford to allocate a lot of funds for all the kids with this problem, but we can at least specify a certain range, for example, for kids up to 6 months, and to give this kind of substances to the kids. We must also, well, at least what we can see here, how we can find a way out. Okay, I will just show you this program and how we provide the support. Why do this children die? Because they have problems with respiratory muscles, and respiratory function can be affected. We have cardiorespiratory monitoring is particularly a must here. We can prescribe all those measures to the child, and we even have a federal program allowing us to do that. For example, in the Sverdlovsk region, there are over 40 children with this kind of device. We have a special mask with ventilation, and those children are already there. So these kids, for example, these special devices that were provided for them, and not with the reanimatologist, but with the palliative doctor, they can really swim in the pool, and so their saturation at the same time really improves. It can also have a direct impact on their pose and the right position on their hands. We help them to rotate. We do that in order to allow them to sit and to stand, to change position. But without that, we can hardly do that. We also perform different operations on their spinal column. Wouldn't be able to do that without. Gastrostoma, different calculators. Gastrostoma, like you said, where did we get it from? From palliative assistance. It means that they can get preschool, school education. They can spend their leisure time in a very nice way. They can even work and study and even have romantic relationships. Or a girl. This, I mean, almost my final slide. This is a cerebral palsy. There was a problem with the cervical vertebra. She couldn't walk almost at all, and she had problem with asphyxiation, and several times she was taken to reanimation, and but we decided to take her to our treatment, feed it for her with some nutrients, and now then her mother sent us this slide. So you see, she can stand on her feet, almost walking. So I think that she can really walk, but what about her legs? This classification that can also be applied here. Previously, we just wanted to make her sit, or maybe just to make her stand without help. But now she has such an autonomy that enables her to do that. What are our forthcoming goals? So we have to cover all those directions of rehabilitation and to develop those packages for that. We need some IT assistance that could help us to do that. But we also should have some interdepartmental cooperation to do that. I think that it is now taken as one of the official classification, and a lot of reference are made to this approach in order to provide equal opportunities for people, such patients. I think that our next speaker will have to speed up a little bit, Natalia Mamont, and now she will be talking about particular kids with conception of early rehabilitation for kids with acute and acquired brain affection. So we will be talking about particularities of early stages and early stages of rehabilitation for this kind of patients. So what is fast track concept amongst neurosurgical patients? This is a system of profound preparation in the post-operational period with maximum early rehabilitation. We need to have this kind of rehabilitation with such patients, and the main task of the doctors is to reveal the reasons and to early diagnose this particular treatment. What is rehabilitation with acute affection of the brain? Acute rehabilitation and early rehabilitation. As for early rehabilitation, it is meant for prevention and faster recovery of the function. The concept of such recovery treatment, just like Linka Beterno said, from the point of view and they should be done. We have children with brain attack, and also a stroke and hypoxia, and sometimes it lasts up to 6 months. As for severe traumas, cranial traumas, it can last up to 1 year, and we need to provide all the opportunities for spontaneous recovery. The basic principle of rehabilitation is a step-by-step rehabilitation, and also participation of some interdisciplinary teams, identification of the potential, preparation of special programs, and a routine of the patients, and should be there based on medicine of proof. How do we do that, and how we developed this concept and implementation of it? Yes. Maybe it could be easier for them to live in patients, but there are also some difficulties. Of course, the main ultimate goal is rehabilitation. Then they take into neurosurgical department. As for multidisciplinary teams, very often interdisciplinary approach is substituted by multidisciplinary. It is needed to tackle some specific prior task. As for the model, for example, reanimation. There they work together with such teams in order to preserve some functions performed by the brain, and during disabilitation, rehabilitologists should form a special team who would be responsible based on the needs of the patients. The prevention program, from the point of view of the medicine of proof in the reanimation department, is presented on the screen. It should be monitored by reanimatologists, and as for neurologists, it's also should be done together with this specialist to perform a full-fledged program for this rehabilitation. It is done in a way where you can see that as for the main goal, it is prevention of different complications. There should be no contractures or those conditions that could prevent further rehabilitations. It should be monitored by neurologist and a doctor of physical medical rehabilitation. We can see scope, character localization, and also the degree of changes in activity and participation, also identification of the tolerance to some physical activity, and all should be done in line with the international classification system. And also we need to consider environmental factors. A few words about the acute stage that also does matter. It is identified by a special chip of damage. It can be also be dependent on the children age, and in this case, if we took all the possible actions, we again might either positive prognosis or provide for some palliative treatment. We also have rehabilitation as linked to the risk factors. A few words about prognosis. It is very important at the early recovery stage, because also routine and program development depend on that further on. Here we use all the possible, for example, spectroscopy and functional method of study. On this slide you can see that MRT performed 1 month. After 1 month we can see already some deformation. The potential is good, but still there will be problem and problem with the right hand side limbs. We understand that it requires very dynamic monitoring. We see that in 6 months, but at the same time we see that we are limited, and kids, for example, might spend only a particular amount of time in this profile establishment. Here we have 2 different scales to assess the remote results and also the efficiency of treatment, and we need to identify all those factors who would work as a barriers. Again, the whole team to work with such a team, neurosurgeons, neurologists, neurologist, interdisciplinary team. We need to maintain a somatic state, and also after surgical treatment, there will be even a more prolonged and intense cooperation. This is one of our patients in quite a severe condition. We had a depressive nerectomy. At the point of view of resuscitation, we had a psychologist right after that, and also then we took some measures to prevent recurrence. And there was a diagnosis that, according to some functional studies, it was not possible to restore some of the functions, and the concept of the early stages is just a development strategy, but in the remote perspective, it's usually we just have an idea to maintain somatic status. We need to identify the reason that prevents recovery. It could be spastic rigidity or other neurologically and chip syndrome. Also, drug supports with regard to that, and also spastics that prevent sometimes the recovery process. The international product of the spastic is performed, presented on stage, again based on interdisciplinary approach, and is used in the resuscitation department. Pain is one of the things that prevents very fast recovery, presented on the screen. Also tolerance. That also affects the program of physical rehabilitation, functional support. That's before should done, after, and during the treatment.
Well, considering this defect with the special cheers, and considering skeletal muscles and cognitive disorders, emergency department, early recovery method, and the main direction of our work is optimization of treatment, early rehabilitation of children, and the sooner rehabilitation started, the better is the result. In this slide we see that early recovery with the watching of 282 patients with the disorders of brain, half of them get recovered at the scale, getting 4 or 5 scores, and the rehabilitation treatment goes through a number of organizational issues, and you can see those at the slide, and before the speakers have already mentioned those. Thank you for your attention. Thank you, Natalia Anatольевна. The next speaker, Tikhonov Sergei Vladimirovich, methodological basis of motor rehabilitation with children. Good afternoon, dear colleagues. As one of my teachers said, I'll try to express one thought in my report, and I hope that you will try to memorize that. Actual methodological basis of motor rehabilitation is a speech for 3 or 4 days, and we will try to make it within 7 minutes. Many of my colleagues before that have simplified my work. They have already mentioned the things that I'm not going to repeat. That is what indicated in wider book. In rehabilitation medicine in Europe, these are main directions where we can be efficient, physical rehabilitation medicine, and where we can help the patient. One of the moments is very important here, that is improve of the functioning and the possibility of social interaction. Whatever we are doing in medical rehabilitation should have a target to improve life of a patient. That is not only performance of some medical manipulations, but as an outcome, as it was meant by Inga Albertovna, assessing by international classification, we should understand what is easier now for our patient, and that should be our main task. A biosocial model of health, which was offered by George Angel, was already elaborated by my colleagues, and the theory, which consists in the point that when there is some disease or illness for a child or an adult, it influences not only physical condition, but it also influences his environment and social participation. Of course, if you are ill, you go to hospital and do not go to work. So you are limited in this respect. You have disorders, not only in the point that flu virus is developing in your body, but also you limit yourself in some communications which you got used to. Main principles of successful rehabilitation of children and teenagers are well known, shown in the slides. That is why I'm not going to describe those in detail. One important point: active participation in rehabilitation of patient himself and members of his family, applicable to children's rehabilitation. It's truly important because, especially at early age, the share of parents' participation will be really high, regardless of the fact that these children, according to new order, well, there is a phrase which I will show you. They are taken into early stages for rehabilitation, and part of their work will depend on the parents. Comprehensive rehabilitation influence, speaking about motor system. Well, we can identify 5 main functional systems which we should influence over from the point of view if we want to recover. Motion function for children. This is functional system of movement, of anti-gravity, sensor sphere, cognitive sphere, and emotional and communication spheres. Well, speaking about functional system of anti-gravity, or probably one of the important systems which makes it possible for us to live in Earth gravity. I believe this is one of the powers which work on us from our birth till death, and we are under the influence of this power 24/7. And there is positive and negative systems over the development of motion system, and we keep on facing that. The coherent apparatus of the system includes circulation system, skeleton muscles, and motion capabilities. 2 words about what happens with our baby before he is born. Nature made it so that 40 weeks, if we are lucky, we get developed in quite comfortable conditions, that is low gravitation. And a baby, when he is already formed, he can perform inside the uterus different gymnastics exercises. He is moving there, he is making whatever he wants. At the same time, there is one peculiarity: there is practically no gravity. That is why movement itself comes to the front part, not sustaining the posture, but namely movement. So the child learns how to move. When he's born, his first task, and what you should memorize today, is sustaining of the posture. That is the main thing which gravity actually pushes us to. So without taking a posture, it's not possible to arrange any further movement. Birth is establishment of basic biological adaptations. After the birth, we are all under control of gravitation forces. And if we start breathing with lungs initially, then adaptation in gravitation fields is stretched for some period of time. And at the best, during the first year of life, when a child learns how to overcome gravity forces. We can single out 3 types of movement which we have at our disposal. These are reflectory reaction, rhythmical movements, and directed movements which are already identified and memorized. Main kinds of muscles control that we have: phase control and tone control. Motor system has 3 levels of management. That is the level of the core and other brain's parts. Motor control, when it is possible to have complicated motion acts. Postural antagonesis, or development of posture, has the most important meaning for the birth, because right from this moment a child has to overcome a force of gravity while performing every specific movement. In order for me to stand here, I had to overcome a force of gravity. For you, when you finish listening to our interesting reports, you will have to overcome force of gravity. And moreover, even when you are sitting, you also overcome force of gravity. Only different kinds of muscles work here. The program of motion rehabilitation of a child is established first and foremost depending on the distortion of cerebrospinal motion control, and corresponds to the ontogenesis of child, and we cannot skip this. And the consequence of formation of motion skills of a person is well known. And here is the idea that I would like you to bring back from my small speech. Three main things. Regardless of the reason of distortion of a motion system of a child, anyway, we will not be able to lose three main positions. The first one is stability, to sustain one position, postural control, reactive, and something we try to recover our child, be it a person with some traumas or whatever. We go through this algorithm. As soon as we have capabilities, we can work at mobility. This is moving capabilities, and after moving capabilities are established, in order for that to move to the skill, according to foreign specialists, it's necessary to make 10,000 movements. Only then this mobility, this skill, it reaches the level of skill, and the brain is not distorted to control that. So we have created a program of movement, and we have recorded in chip, and then we do something else to create another skill. Conclusions. A child is born with a motion experience which he gets before delivery, and this should always be considered, that in uterus development is also development of motion experience for a child. The second, stabilization of posture and body, develops within the first years of life and creates a basis for further strengthening into vertical position. Scarce of postural skills can become a reason of postural disorders during further development. In every 3 years of 3 months of the first life, we see some notions of moving forward and straight position. We can identify 4 quarters which are principally different from each other with the stage of moving development, motion development. So every 3 months, a child is doing something globally. Well, and during the first year of life, the child remembers his individual basic algorithm, which he is going to use for the rest of his life. I assure you that whatever you learned to do at the first year of your life, you use it right now with some specifications. If you have not done active sports, if you have not developed additionally, it's all that you learned during the first year of life. And just a few words about what were mentioned by my colleagues, new degree of Ministry of Healthcare about medical rehabilitation of children. And here you see date and name, and if you need this, you can take a picture of that, even though it is said correctly by Svetlana Andreevna. It's available at the consultant, at Garant, at Children's Rehabilitation site. You can download this. So the main thing that is a new order, and what is lacking in General Order 1705 from 2012, is that medical rehabilitation of children is done in maximum early periods from the start of the disease. And I would like to invite you to our annual International Congress, 23rd, 24th April, 3rd International Interdisciplinary Congress, Tradition and Innovation in Moscow, holiday in Sokolniki. Thank you for your attention. Thank you very much, Sergey Vladimirovich. And the next speaker for 5 Ekaterina, methodological basis of cognitive rehabilitation of children. Good afternoon, dear colleagues. Well, I would like to speak about cognitive rehabilitation. Of course, speaking about methodology can take us a very long time, regardless of the fact that cognitive rehabilitation is quite a young science, and it got its development from the middle of 20th century, when basically in Russian psychology, Alexander Romanovich Luria created a model of neuropsychological rehabilitation of patients after brain distortions. What we are going to speak about today? We are not going to speak about inborn pathologies. According to American statistics data, most children are children with acquired brain distortions. Those can be traumatic or non-traumatic, and in many respects that is related to the point that light cerebral cranium trauma, like in American football, is the highest problem of American cognitive rehabilitation now. Well, at a modern stage, cognitive rehabilitation starts parallel to treatment process. That is something that is reached up today and at the territory of Russia. And after some treatment, or when a child is taken home, we're not going to speak about organizational models, as long as organizational models largely depend upon the structure of healthcare in different countries, and within the frames of our country, it depends on regions. And we're not going to discuss immediate methods of cognitive rehabilitation methodology, because they depend on these or that nosological groups. But today we'll try to arrange basic moments related to children cognitive rehabilitation. And children cognitive rehabilitation was based on researches within the frames of neuropsychology, behavioristic psychology, and main methods that we sometimes use during the work is, of course, confirmation. It's not in cognitive rehabilitation, but during the classes with children, parents often just confirm, you've done it good, or you've done it not very good, you could have done better, or they direct the child somehow. So all these methods came to us from behavioristic psychology. And of course, cognitive psychology is the dependencies or function of these or that cognitive functions. So, if before it was considered that cognitive rehabilitation is only about recovery of cognitive function, then we are speaking about that actually cognitive rehabilitation is considered in a wider sense, that is an improvement of functional capabilities of children or patients in everyday life after the brain distortion. Model of cognitive rehabilitation is shown at the further slide, at this slide, and this is the model done by neuropsychologist Barbara Wilson. And the most important thing here, the most important thing here is that in the center of cognitive rehabilitation, there is a patient with his problems. These problems, depending on the type of distortion of brain, are classified by several directions. These are cognitive problems for neuropsychological problems, psychological problems, behavioristic problems, and for every type, assessment for different groups, and a patient and his family in all the directions. So, well, Barbara Wilson often says that nosology is not important for us. I do not support this opinion because, on the other hand, the proof medicine goes from the part of so-called nosological groups, and there are kind of methodologies which should be used, for example, in oncology or at heavy traumas, including children's insults. And when we assess cognitive, emotional, behavioristic problems, it can be realized in different approaches of neurorehabilitation. It could be realized in traditional approach, so-called pathogenetically explained approach by Mr. Luria, when we identify a change in the mechanism of function distortion, and also in pragmatic sense, when we try to consider how to adapt patient to his cognitive problem. Different strategies of cognitive rehabilitation may happen, and at the first stage or second or third stage we have some specific combinations. And the most important question, whether it's sufficient to have cognitive rehabilitation, and we often hear it from doctors, and addressing this information, we have historical data and we have data of modern research. And at this slide you see that this is quite a famous experiment of Hebb on in enriched environment, when rats were put in a different environment, and they had novelty effect, a simple environment, and so on and so forth, and they identified that, so they measured the core width, and those who were in enriched part of the core was wider, and the skills were perfect, and we can directly communicate it with the efficiency of cognitive rehabilitation when we arranged this process as early as possible, speaking about brain distortion stage. And we related to which influence is more efficient, and here we should speak about different types and strategies of cognitive rehabilitation. Sometimes we can work with the patients, sometimes there can be groups of patients where we explain what has changed after the trauma, which are the consequences, and one of the researches was done where we very clearly showed that. At this slide you can see the data of resting state functional MRT, that is when a person doesn't have any tasks during MRI, but we analyze the connections between specific areas. So two groups of patients were divided as to the training type. One of the groups was going through cognitive rehabilitation as to immediate rehabilitation with the patient, and in this case it was related to memory, and the other group was related to memory, about the methodology of memory improvement. And only in the first group, when immediate class with the patient, this group of patients showed improvement in singular peripheral area and in forehead area. And what kind of methods? One or several? Actually, it's very important to combine the methods, and that shows efficiency at cognitive rehabilitation. A few words about peculiarities of cognitive rehabilitation for the children. That knowledge, skills, and capabilities of a child cannot be compared to knowledge and skills of an adult person. We should always understand that a child is at the stage of development, and so within the frames of rehabilitation, we should not only bring back after the brain distortion
and to do it for maximum possible restoration of cognitive potential, but also provide for an opportunity to develop further. This is data that affection in the early ages might have more severe complications when the affection taken to the type of the stage of formation. Here we can hear the frequency of sensory attention deficiency syndrome, and people with severe cranial injury, they might really be there to reveal this kind of syndrome, and also hyperactivity. And a few clinical examples that meaning to say that we also wanted to accompany the risk of any of those symptoms. It's very difficult to maintain this program with kind of provocation on the reverse side of the sheet. Even at the early stages, we try to help kids to restore their skills and also to remove all those defects. With those who hold optical space, nausea, and together with a specialist, we can help to create the full picture in case of this pathology. On this slide, you can see an early data from patients and also monitoring over the first half a year during regular training, also during agnostic training as well. One of recent examples which tells us when you properly reveal distortion of a mechanism, it can lead to a good functioning of cognitive potential of the kids. Well, here we have kids after a very severe cranial trauma. We can see that here the cortex was affected, and here you can see diffuse or axonal affection of lobe parts, and the recovery was really fast. And they are here presented. We see the clinical picture, but also we can see that there was quite good results. And when she was taken in 4 months for another medical checkup, and the point is that she only ignored some of the parts of the page of the sheet, and she had a problem with the left-hand eyesight. As for cognitive rehabilitation, it's also accompanied with some drug treatments. We asked them to copy some of the figures and also to identify difference between different signs. So this is clinical example, but if it was different, the program was also different. But when we have certain assistance on the left hand side, you can see the second figure that is being depicted. It is done with the help of a specialist, and in this case, our program was a little bit modified for this child, for training her development skills. But after class, you can see quite a good positive dynamic for that managerial functions. What are the major things that should be mentioned here during cognitive rehabilitation? So cognitive rehabilitation today, this is all about early accompanying of such a child at the early stages. Also shouldn't forget about diagnosis based on international clinical recommendations in line with the group that we have been working with. And unlike parents, not like in the children's group, it needs to also to monitor the contaminants and also different stages. They need to be interlinked between each other, so that when a child is handed over from one establishment to another, we could learn a lot about his or her cognitive functions. Many children, when they come from one establishment to another, scales are the same, and so that is why we can use the same data for further analysis without any disruption. Thank you very much. If you have any questions, you will ask them later. I'm sorry, we have two more presentation. Olga Vasilievna, please. Olga Page, support for kids with speech disorders. So you unfortunately will be given only 5 minutes. So I'm sorry, I'm just will be sitting because I was a little bit traumatized not long ago. So I will just follow the example of the previous speakers and will formulate my idea at the very beginning, and then we'll just illustrate it a little bit. Up to year 90 in our city and in our country, we didn't have any problems with logopedic rehabilitation. So it means that kids with speech disruption, they were taken to a very special ambience that was presented by and formed with the participation of many establishments. But when the finances allocated by the Minister of Health modified the way we know today, and all the specialists were found outside the obligatory medical insurance programs, another situation occurred. Right now, children who have problems with their speech or speech disorders, they practically have to search for such assistance, but at the same time it cannot be rendered to everyone. Of course, I'm talking about free assistance. And another disadvantage is that apparently the whole domain is being exposed to some amendments. Right now we had children, and we said that they had some speech disorders, problem to pronounce certain words, grammars, but now we understand that at least, well, in many cases, not all of them, but overwhelming majority of them, there are some more serious disruption behind that, and especially psycho-speech development disorders. So it's a combination of two, and not just a speech disorder. And so, always when parents approach us in big quantities, and sometimes they exceed our capacity, we had the following problem. What is the main difficulty of the child? So what do parents say? Parents say that, well, everything is fine with his brain and head. We just have a problem with a speech, and specialists put many efforts into showing them that speech pathologies, it's one of the consequences of problems with psychological development. And when we review all those symptoms they can see on the slide during our checkup, we understand that in order to start working with the speech, we need also to take care of all the other sides of psychological development. Even if you analyzed the past 6 months and how many applications we received, we see that in most cases we have light, not light, but medium and more severe stages, and usually it falls within the group of those of 2 or 3 years old, because it's exactly when their speech patterns are formed and they manifest the main parts of the psychological development disruption. But if we compare the number of children with purely speech pathology marked in blue and the one that is apparently also complicated by another pathology of psychological nature in red, then you will see that if, for example, children in 2 or 4 years, here we only have 60%, but 88% of the children with well-pronounced speech disruption apparently have psychological symptoms. It is revealed, of course, and manifests itself in different ways, but I'm not going into details here. As for ontogenesis and dysautogenesis, we can see a lot of them, but these are children who came over not with a problem with the head, but those who said that they had only problems with the speech, and also have very serious psychological problems with the parents. We have to overcome them, because unfortunately children are taken to us not at early stages but at the age of 5 or 6 when they're about to go to school, but for some reason before that, at that moment, they already have some diagnosis at their hands that are put forward. It's a light way, and They show some kind of notes for us to state that they have no problems with overall development. Sometimes they were offered to use some non-traditional developments, for example, to work with dolphins. Attitude is quite negative. These three problems, we can see them and they go together. So usually it's all about late notification, disadaptation that appears against the backgrounds of low grades and a whole spectrum of different problems with further development. That is why the so-called logopedic support is not about a speech specialist, but the whole complex of assistance that can be provided for such kids. And it is aimed first and foremost not at forming all those normative sounds and proper pronunciation as well as vocabulary enrichments. No, we're talking about all functions and resources. That is why all those kids with speech disorders, this is exactly what they need at this very stage. And the practical aim right now is not to form behavioral or speech patterns, but psychological integration of the child, because this is all interlinked. We considered this demands on behalf of the population and also their needs for this logopedic assistance. And we decided to segregate it into three main stages. So we decided to add this pre-hospital block, which wasn't the case in the past, and previously we used this kind of scheme. So first we received an application, then the child was sent for a consultation to a specialist, and then we proceeded to a special professional concilium and a selection commission that decided on the further routing. So it was either an outpatient or inpatient treatment. Here are the options so that can be provided by the selective commission. As of today, we decided to make a step forward, and we ask them to join us for some consultations. Then they go to a speech specialist and then go to a selection commission. And as for this pre-hospital stage, it allowed us to decrease the number of children needed for further days spent in outpatients and inpatient hospital. We preserve pretty much the same situation, but the cohort is the same. Again, we have more boys than girls, but as for the age, yes, it's mostly kids of 5 or 7 years old. So this is too early to talk about early since we already have some disruptions. They manifest this kind of symptoms and the problem that I started with. So apparently we can see this, and speech cannot be withdrawn from the context of psychological development, and as a result is just something that points out to some psychological problems. So that is why, if you want to think about that, so then thank you very much. And the last speech will be delivered by Ponomaryova, Chief Doctor of the Children's Sanatorium, and she now developing a new pilot project with a number of authors. Brakov, Lutin, please, over to you. This slide will be in the end, so if you don't mind, we'll be just sitting. You will have to spend here just another 5 minutes. We are a little bit behind the schedule. Yesterday we had a fantastic section at the assembly where we thought how we can work with the ministry, and over the past 2 years, under the guidelines of Svetlana Albertovna, a lot of projects were put into place, and the results of some of those projects will be shared today. So the goal of our project was to improve the quality and availability of sanatorium and resort treatment for children and those who have the indication for this kind of treatment. Our project started on the 1st of June in 2019 and was finalized on the 31st of December in 2019, so within a period of 7 months. In order to implement this project, we decided to choose two bronchial pulmonary sanatorium located in the Moscow region. The first one is number 68 with 30 beds in the town of Pushkin and in town of Korolev. The age was from 3 to 11 years, and another one with 15 beds, and the age was from 2 to 12 years. In order to implement this project, a separate landline was allocated that was given to a person in charge having all the possible information, and the person who knows how to react to different situations. We prepared a full-fledged infrastructure for hospitalization various kids of different ages, and it was done in full correspondence with all sanitary requirements. We also had a nursing stations that are used as a reception department. We had a separate entrance for patients, different procedures and filtration during patient inspection just to spot their probably infectious diseases. So here you can see that we also had special list for hospitalization. We pointed out their attention to the fact that there should be a particular procedure where they had to take their kid back on the last day of the treatment and the program. It included a number of different steps. They were examined by specialists at least 3 times while entering the course, during the course, and before they left the camp. And upon completion of the course, authorized person provided all the necessary normative documents, all those, and also decrees. Information about our pilot project was taken to the consumer using social networks, and accordingly it was done via official websites, via different polyclinics, and authors could ask us different questions using the special landline, and also make a personal call to the sanatorium. After that, they filled in all the necessary documentation on polyclinic, and upon approval of the date, they came to that camp and could get a full set of documents that was then returned to polyclinic. We analyzed the functioning of the beds starting from 2018. There was 6.4 beds, and then 12.4 in 2019, and during the pilot version it has grown by 2 times, as you can see. So 7.6, 6.7 against 12.7. Rehabilitation becomes continuous. As you all know, the main principle of rehabilitation is that it should be continuous. Then we also ensured a practical preparation of the beds pool for medical rehabilitation. Realization of the project had no impact on the epidemic situation. We also received some positive feedback from authorized representative of the patient, and also from the parents of school children who could really saw some results. And here are the conclusion. The methodology of assistance provision, the framework of the project allows to make it more consumer-oriented and to improve the quality of the treatment. The methods as well as methodology allows us to look at this issue from a different angle, and also to think that they could be used for children with somatic disorders. As for these establishments, under 8 and 68, they were organized and rearranged in line with all the necessary requirements. At the same time, visits could also visit their children, and thus they receive certain treatment later and also rehabilitation. And the flows of children were also well properly organized and arranged. It allows to fully comply with our ultimate goal. Here is the working group of our project. So Svetlana Valiulina is our chief general management. Burakov Alexei was responsible for the general design, and Dementieva Irina Nikolaevna and Ponomareva Irina Anatolievna were responsible for the implementation of this pilot project. Thank you very much. Thank you very much. We are 12 minutes late. Do you have questions? Just 1 or 2 questions? Then we are ready to answer them. Thank you very much for your presentation. I have a question for Olga Silirina regarding the presentation. I was exposed to a situation where, in the Moscow clinics, they know nothing about your center.
Oh, well, in which clinics exactly? In Moscow polyclinics, neurologists, for instance, my child was treated in your center. I'm very grateful for that because it's really amazing result. However, in order to know about this and come to you, well, it was just by chance. Specialists are not well informed about the fact that such center exists, and it's not only a question, but it's a wish for your center to be more described. Thank you. The thing is not they do not know. The thing is that unfortunately polyclinics do not know or do not forget that our institution does not work by obligatory medical insurance. It's related to psychiatry, psychiatric profile. It's of principal importance because it is financed with the budget of Moscow, and it does not take any ruble from obligatory medical insurance. But doctors in polyclinics, for some reason, believe that if they direct a patient to some other institution, they will lose money. For many times we told them that you're not going to lose anything, that we get financing from different purses. However, well, we cannot influence everyone, and still some of them have some cautious treatment to that. And if I speak how many actually people have more than 1,000. These are so many things, and everybody knows in polyclinics, but there is an incorrect explanation. And she's a main specialist in medical rehabilitation, well, of eastern part. And as a pilot, you can arrange this work so that polyclinics could send to us. Well, thank you. That's the explanation. And if you have any other question, then thank you very much. Thanks to all the speakers. And if I may, just a few words. Our colleagues will have a good news. On 16th of January, Ministry of Justice registered changes into the regulatory of specialists with higher medical and pharmaceutical education and added it with the profession physical and rehabilitation medicine. Now we can officially get certificates and we can arrange training.